So, hello everyone. Today we are going to discuss a very important topic, that is hyperkalemia, and it is a critical electrolyte emergencies in clinical practice. So now we are going to discuss this. What is hyperkalemia? First we going to discuss this. Hyperkalemia is the condition in which serum potassium level is greater than 5 m equivalents per liter. So before going to discuss detailed description about hyperkalemia, let's talk about what is potassium and their functions into our body and why it is normal to maintain its value at normal rate. Potassium is the main intracellular cation, meaning most of the potassium is inside the cells. Rationale behind this, only a small amount or fraction of potassium is in the blood. Otherwise, small amount of into the blood, but even small amount increases serum potassium levels significantly and affect the electrical activity of the heart. So when potassium rises, it becomes dangerous because it directly impact on cardiac conduction, muscle conduction or nerve transmission. So potassium controls the resting membrane potential of excitable cells. Even slight imbalance can disrupt electrical stability. So, what are the major causes of hyperkalemia? There are three major causes of hyperkalemia. There are three major causes of hyperkalemia. First is increased potassium intake. Second, shift of intracellular fluid compartment into extracellular fluid, and third is the decreased renal excretion when there is a kidney issue. So these are the only three ways serum potassium can rise. Either more enters the body rather than into the cells, or more leaves the cells, or less is removed. It is known as spike in potassium into the blood, which is too dangerous. It is a life-threatening situation which can cause cardiac arrhythmias and sudden cardiac death due to cellular depolarization blockage, because there is a delay in contraction activities which directly leads to heart failure or cardiac arrest. Heart is going to fail and stopped. So it is there is one clinical tip which is you need to remember always. Hyperkalemia is rare in healthy kidneys. So kidneys are the primary organs that excrete potassium. If they are functioning well, excess potassium is efficiently eliminated. Is this clear to you so far? Do you have any doubts until this point? You can ask me without any hesitation. So if you are okay with this, let's move forward. What is the pathophysiology of hyperkalemia? It is characterized by serum potassium level greater than 5 m equivalent per liters, as I have told you earlier. Potassium acts as primary intracellular cation, and it affects the cardiac, renal, neural and muscular tissues as well. So we need to remember this. Next, we have to discuss their major risk factors. First is increased total body potassium. When IV potassium overload is increased, rapid infusion increases extracellular potassium faster than cellular uptake or renal excretion. So this is the major reason. Second is the unmonitored potassium salt substitute. What is substitute? Substitutes is a product the hypertensive patients or salt restricted patients have been using instead of regular salt. It can increase the potassium chloride into the blood, and which generates spike in potassium. Third is the aged blood transfusions. When we give an aged blood transfusion to the patients, there is a tendency of RBCs to broken down, and broken RBCs release abundance amount of potassium into the blood. So You need to remember this. Always transfuse fresh blood to the patients who have kidney problems especially. Next, intracellular shifts. Internal transmission from the intracellular to extracellular fluid. How it happens when there is a acidotic state in the body. Tonic states, hypertonic fluids into the body like sugar. In diabetic ketoacidosis, there is a tendency to move hydrogen ions into the cells and forcing potassium out of the cells. It can directly leads to spike in potassium into the blood and cause hyperkalemia. Next, insulin deficiency also lacks power to drive potassium back into the cells because normally insulin acts when we eat meal. Normally when we eat meal, understand this, pay attention on this. When we eat meal, insulin releases from our body pancreas, and it directly pushes our glucose into the cells, and it stimulates the sodium potassium ATPase pump, which help to regulate and directly transports the potassium into the cells and while sodium out of the cells. So this is the normal process. If it is disturbed, then it will happen. Next is tissue catabolism. What is tissue catabolism? When there is a surgery or a breakdown in tissues, there is a tendency to reserve potassium or leak potassium into the extracellular compartment, which directly leads to high potassium volume into the extracellular compartment and cause hyperkalemia. Next, there are some other risk factors as well. So, decreased excretion and age factors are also responsible to increase potassium into the blood. Renal clearance barriers, example, inability of the kidneys to filter or excrete potassium, the absolute most common cause of high levels of hyperkalemia. So, kidney failure or decreased glomerular filtration rate below baseline can reduce the ability to excrete potassium. Severe dehydration also cause a spike in potassium because low perfusion of nephrons can directly impact the filtering capacity of the kidney, and retention of potassium is common in them. Next is adrenal crisis. When there is adrenal crisis, there is interruption in releasing aldosterone hormone, which is directly reabsorbing the sodium from the kidneys and excreting the potassium, but its inability can cause hyperkalemia. Next is the medication blockers. When patients having potassium sparing diuretics or AC inhibitors, it blocks the renin aldosterone path like angiotensinogen 2 blockage. It has ability to block angiotensinogen 2, which releases aldosterone. If there is a not aldosterone, then there is a tendency to retain the potassium into the blood and cause hyperkalemia. So major factor is that also. Next, we also remember the aging factor as well. When patient is aged and their kidney functions might be slow and their filtering capacity is also lower down, so this is the main risk factors of increase in potassium into the blood. Next, we have to discuss the clinical findings of means sign and symptoms of hyperkalemia. What patients can feel when there is a hyperkalemia. First of all, cardiovascular system. We have to check vitals. In hyperkalemia, patient may suffer with bradycardia, slow pulse or irregular pulse, and their cardiac electrical activity has some lethal changes. Systematic atrial hypotension due to low perfusion of blood, and there is decrease in cardiac output and contractility of the heart, then slower downing the function of a heart. Critical rhythm changes can be occur, ECG changes maybe takes place. So major point is to focus on cardiovascular system when there is a high potassium levels into the blood. So if you have any doubt until this point, you can ask me any question, and if you don't understand the concept which I have taught until this point, you can ask me anytime. So next we have to discuss the gastrointestinal hyperactivity. When there is a high potassium, increase smooth muscle contractions, especially into the intestines. That directly leads to irritability, and the patient may suffer with hypermotility and diarrhea, which creates cramping and pain into the colic pain into the abdomen, and hyperactive bowel sounds as well, which leads to irritation. And other is the neuromuscular skeleton system problems are there. Patient may feel paralysis like symptoms, like they have initially starting with the paresthesia, tingling sensation or irritability into the lower limbs, and ascending flaccid paralysis means paralysis starts from lower to upper, from lower limbs to upper limbs. So there is a tendency to absent deep tendon reflexes in patients with hyperkalemia. So we need to remember this. Next, the major changes in ECG, we have to remember this. In hyperkalemia, this is the main factor or symptom. As potassium rises, cardiac repolarization speeds up, means charging of electrolytes is very rapidly, and depolarization slows down, means cardiac contractility delayed, and it becomes more time, it takes more time to contract the cardiac muscles, so it can directly leads to changes in ECG. This create distinctive highly productive electrocardiogram changes. First, peaked T wave. Peaked T wave means repolarization is rapid acting. Recharge electro recharge electrodes very rapidly. So indicate rapid ventricular activity leads to peaked T wave in hyperkalemia patients. Next is widened QRS complex. Why it widened? Because there is delay in contraction in depolarization. So that's why intraventricular conduction is delayed, and it causes a wider QRS complex again and again. Are you able to understand what I'm saying? So next, if you don't, you can ask me anytime. I will answerable and repeat that concept again. Next is the PR interval extension. Progression to complete AV heart block and arrest. And if hyperkalemia is potassium is more than 6, then there is a tendency to block or stop heart. So this is all about ECG changes. Let me explain you again. Peaked T wave means faster ventricular repolarization due to increased extracellular fluid of potassium. Extracellular fluid can increase the rapid charging of the cardiac cells or cardiac electrons, which directly leads to peaked T wave. Next is the widened QRS complex. Why? Slower ventricular contraction due to impaired sodium channel function. it leads to widened QRS complex. Next is the ventricular fibrillation as well. Patient with severe instability leads to chaotic ventricular activity. So that's why there is a chances of a ventricular fibrillation because heart not pump blood effectively. So that's why it happens. So ECG changes you need to remember must into the hyperkalemia. So next we have to discuss patient-centered nursing care. What we need to remember: immediate diagnostic reporting to the physician. Report telemetry changes or any critical lab findings outside safe references. If there is more than 5 potassium into the blood, you have to immediately report to the physician so that they can manage this on time to prevent the life-threatening situations. So what are the lab findings you need to remember while you think about hyperkalemia? First is the serum potassium levels into the blood. Second is the most important indicator, ABG analysis. ABG analysis helps us to understood if there is a metabolic acidosis as well with the hyperkalemia. So we need to balance this. In metabolic acidosis, the pH is less than 7.35. Okay, so ECG will show dysarrhythmia. There are three indicators which we need to remember or check in hyperkalemia. First is serum potassium levels. Second is the ABG analysis for metabolic acidosis. Third is ECG changes for dysarrhythmia. So we need to remember three mostly. Next is patient-centered nursing care. What we need to provide them, that is immediate diagnostic reporting to the physician so that they can take action to prevent from further complications. Second is strict intake restrictions. Discontinue all ongoing IV infusions, all oral potassium supplements what we have taken instead of regular sugar or substitute anything else they can take, we have to restrict them. Third is the telemetry integration. Place the patient on a continuous monitoring and rhythm strip should track. This will rapidly evaluate the blocks or fibrillation into the ECG. If there is any slight changes, we can protect the patient by giving certain kind of medication on the order of doctor, physician. It is the nclex important or main tip. We have to remember the ECG changes which help us to recognize the answers while we are going to take exam. Fourth is the vascular patency. So maintain patent IV lines so that we can rapidly access for antidote administrations while there is a risk of getting worse situations. Next, we have to discuss about the medical management as well. First is the shift potassium into the cell. How we can shift potassium into the cells. It will helps to reduce the circulating ECF, extracellular fluid potassium, by driving it intracellularly. It can be managed with the help of IV dextrose and regular insulin. Regular insulin is used as a neutralization into the dextrose 50% or 25%. What your doctor ordered, you can use them. Insulin act as the carrier to slide potassium into the cell membrane. Dextrose is given concurrently to prevent severe hypoglycemia. So this is helpful in putting potassium back into the cells from extracellular fluid compartment. Second is the soda bicarbonate. It helps in maintaining a metabolic acidosis. Indicated if hyperkalemia is driven by metabolic acidosis, then we have to given soda bicarbonate which helps directly in moving back potassium into the cells. Their functions are same, their work are same, but we have to given them with the help of physician's order only, not with your own choice. So next is second point, active potassium clearance. Okay, actually eliminate potassium from the biological system permanently. It helps to move potassium directly through excretion method. Sodium polyestrine sulfonate is the K bind sachet which binds potassium inside the GI tract and excrete directly into the stool. So it is helpful. And we can also use loop diuretics if ordered by physician, that is furosemide. Loop diuretic drives renal excretion. Only usable if kidneys maintain sufficient filtering pressure. So we need to remember this. Next, if you have any doubt until this point, you can ask me anytime. Next, we have to prevent myocardial muscles, or we have to stimulate cardiac function. We need to give calcium gluconate if there is a dysrhythmia. Calcium gluconate uh, immediately protect the heart from cardiac arrest. And in case of patient with rapid blood transfusions, there is a risk of a hypocalcemia as well, because the citrate present in the blood bag, there is a risk of binding citrate with the calcium gluconate present in the blood after transfusion. It directly leads to decrease calcium gluconate from the blood, which directly leads to cardiac arrest. So we have to replace calcium gluconate as well to prevent the patient from hypocalcemia or cardiac arrest as well, because it is directly responsible for heart rhythm. So this is all about that. Now we have to remember one thing also. Before going to give oral or through bowel enema, sorry, give me 1 second. Okay, bowel sound safety check is must when you are going to give enema, because if there is no bowel sounds, there is a chances of bowel necrosis. So you need to remember this. There is a high risk of causing fetal bowel necrosis. So before going to give enema, you need to check this, then give enema. And if there is conservative management or all medical management is not able to work, then we have to put patient and ready patient for CRRT, that is continuous renal replacement therapy. It is for 24 hours. We have to give and ensure early steady with using a 1 ml per hour heparin as well to prevent the formation of clot or prevent extracorporeal circuit clotting. Okay, so you need to remember this. This is the dialysis machine. Next, what you need to remember, all right everyone, that completes hyperkalemia. We covered today causes of hyperkalemia, pathophysiology of hyperkalemia. Let me review all lecture in between 1 minute. So we have discussed we have discussed in detail about potassium. What is potassium? Most abundant cation which helps in sodium potassium ATPase pump and move potassium into the cells and while sodium out of the body. So this helps in the nerve conduction, cardiac conduction, and muscle activities. So we need to remember this. What are the causes? Causes are administration of IV potassium, inability of kidneys to excrete potassium, or retaining of potassium into the blood. This is the main reason. And shift of intracellular fluid to extracellular fluids. These are the causes. Then pathophysiology of hyperkalemia, how hyperkalemia occurs into the body by using salt substitutes, and when there is a uh, transfusion of a lot of blood can cause hyperkalemia. There are some basic things we need to remember. So what are the clinical symptoms? Changes in the vital signs. Patient may suffer with the bradycardia, hypotension, and there is a chances of irritability, confusion, and paresthesia, tingling sensation, burning sensation into the limbs. So patient may experience this. And most important clinical signs are ECG changes, ventricular fibrillation, patient's heart are not able to pump blood effectively. So peaked T wave, widened QRS complex. As I have tell you why T wave is peaked, because there is a repolarization, rapidly repolarized uh, by cardiac muscles. So widened QRS complex and cardiac arrest is the time when there is a failed system. So GI motility increased with the help of high level of potassium. So that's all about the clinical signs. So what are the basic diagnostic criteria which tell us there is an increase in potassium in the blood? That is, serum potassium level into the blood more than 5 is known as hyperkalemia. ABG analysis. Why would we do ABG analysis? For metabolic acidosis? pH is less than 7.35, it means metabolic acid. We have to replace soda bicarbonate if there is a metabolic acidosis. Serum potassium, if there is a 5, then we have to uh, given a neutralized solution like dextrose by neutralized with the insulin, because insulin insufficiency can cause hyperkalemia, as I have told you. So ECG changes also tell us there is a hyperkalemia, T peaked wave. I have already discussed this. If you have any confusion, you can ask me. We also discussed nursing care regarding hyperkalemia. First, reporting is important. Decrease potassium intake is very important. Promotes the movement of potassium from intracellular extracellular to intracellular. How it will promoted? By giving dextrose with neutralized insulin. So monitor cardiac rhythm uh, consistently and interventions promptly as needed. So prepare the client for dialysis if there is no work with conservative treatment, means medical treatment. So we should do this. So we can also, one thing I forget to tell you, we can also nebulize the patient with albuterol, because it contains beta adrenergic agonist that send potassium directly into the cells. So we can do this also. So at last, after finishing this lecture, I would like to give you certain questions before. And is there any concept you would like to repeat or clarify? I can do this for you. So there are some cases you need to understand. A client with, first question is a client with acute injury has a potassium level of 6.2 m equivalents. The telemetry monitor suddenly shows peaked T wave and a widened QRS complex. Which provider order should the nurse implement first? Administer sodium polyhydrogen sulfate orally, IV infusion with dextrose and regular insulin. Administer IV calcium gluconate slowly over 15 to 20 minutes. I will provide you these 5 questions after finishing this lecture. You can go through with them and you can understand the priority when we are going to choose answer with the question. Okay, that's all about our today's topic.